Welcome to Heart Failure Unfiltered. My name is Nick Hartshorne-Evans and I'm the founder and CEO of the Pumping Marvellous Foundation, the UK's heart failure charity. Today, we'll be discussing Beat to Treat, an opportunity to improve the time to diagnosis, treatment and management of heart failure. A podcast about heart failure and why the simplest ideas often save the most lives. This podcast asks one question over and over again. Do we have an opportunity to create a paradigm shift in recognition, diagnosis and treatment of heart failure? Because if we don't understand the increasing prevalence of heart failure, how do we act? So this afternoon, we're at the Liverpool podcast studios and I've got some fantastic people with me today.
Hi, I'm Claire Taylor. I'm a GP in the NHS and Professor of General Practice at the University of Birmingham.
Hi, I'm Rajiv Sankanaran. I'm a heart failure cardiologist in Liverpool.
Hi, Fozzie Ahmed, heart failure cardiologist, Manchester.
So, what a fantastic team we've got today. And we're going to be talking about a concept called Beat to Treat. It's a bit more than the concept now. It's moved into pilot stage. So, question, Rajiv, because you are the clinical lead for the Beat to Treat programme. When it comes to heart failure, where do we lose the most time? And is it at the diagnosis that it slips away?
I think it's both. It's about delays in diagnosis, but also delays in initiating treatment. And it's about bringing those two together and addressing both of those simultaneously. That's where the solution lies.
So, but the delay is at diagnosis, isn't it?
Yeah, that's where the problem starts. Yes. So it's it goes back to BEAT, and that's how we developed Beat to Treat. So addressing the delays in diagnosis by popularizing BEAT and symptom awareness, both for the public and clinicians, is one of the solutions.
The Beat to Treat's a bit of a hybrid of BEAT, isn't it?
Yeah, so it's about looking at the root causes. So delays in diagnosis, yes, but historically we've sort of separated these things, the diagnosis, the investigations, and the treatment initiation, both in sort of time, space, person. So it's different settings, different people, different investigations. So it's about bringing these together. And it's about coming up with a turbocharged solution. It's like a gegenpress. You sort of get this going, but keep at it, bringing everything together in a one-stop setting. So get the investigations, get the diagnosis made or excluded. But when the diagnosis is made, you get the life-saving therapies initiated as well. So that's bringing Beat to Treat together.
Because currently across the UK, we're looking at 6 months, maybe.
Yeah, again, it's variable. So some places are managing to achieve things within the restrictions of whatever's happening. COVID sort of added to a little bit of delay as well. But even before COVID, it's been a problem which has been there for several years, as Fozzie and Claire will tell you. So it's not something new. We've always struggled to keep on top of things, and that's because it's a condition. So there's a predicted doubling of heart failure. So it's an aging population, lots of new long-term health conditions being diagnosed. High blood pressure is one of them. So there are lots of people who are going to get diagnosed with heart failure. It's about preventing the condition, but also diagnosing and treating those who have the condition. So it's about...
So what we're saying is that patients recognise the symptoms before the system does.
I think, they can do. And I think that's why we created BEAT and the BEAT acronym to start with, is to raise awareness of these key symptoms, which we are reliant on patients, their families, communities to recognise, so they can then come to us, usually in primary care, to say, I've got these symptoms. Then us in primary care need to think, could this be heart failure, and do a simple blood test. So the T for simple blood test and natriuretic peptide test we can do in primary care. And if that's raised, then we do need an echo and specialist assessment to confirm that diagnosis. And that's the gateway and the key to the life-saving therapies. And I think Beat to Treat is really trying to enable that whole process and that whole pathway to be a bit more seamless than it is at the moment for patients. So I think in the areas where there's the pilots, a GP having access to these direct clinics where you can get an NT-proBNP blood test, an echo, and treatment initiated within 60 minutes. I mean, that's just really exciting. And, that pathway can take months, as you say, Nick, in the usual NHS at the moment. So I think it's looking at this very different model of care to get that rapid diagnosis and treatment initiation started sooner. But it does rely on that symptom recognition to start with, and patients coming through the door to us so that we can then get them into this new pathway.
So I remember Professor Martin Cowie saying to me something similar to, we know what to do, we just don't do it. So we know a lot, but are we implementing that know a lot? So Fozzie, where do people get stuck between diagnosis and action?
I think that sometimes it's red tape treacle. Sometimes it's, you get it getting moving along the system, that you get stuck in the inherent delays. You get stuck in the waiting list for diagnostics. You get stuck in the waiting list for clinics. So I think being able to say to patients that actually if you have these 3 symptoms, the breathlessness, the exhaustion or effort intolerance and the ankle swelling, then that you automatically meet the eligibility criteria. Or you qualify for this test, this blood test, and the test is often done alongside other blood tests, rule out anemia as a cause of breathlessness, iron deficiency, heart failure. So I think there are process efficiencies that we can do, that we can learn from. We need to do things radically different if we want to solve this problem and stop just reporting on the numbers getting bigger and bigger. So if we want to tackle the solution, we need to tackle it at its source, where it exists in the community, and give patients direct access to specialist services without the friction, without the barriers and obstacles.
I mean, this, Beat to Treat, we'll talk about it in a little bit, where we can identify, diagnose and treat within 60 minutes, where, I am aware of areas in the country where there's 12 months between identification and a consultant cardiologist actually doing that diagnosis and issuing those prescriptions. But we're doing it in 60 minutes with Beat to Treat.
And the key thing is that there are no shortcuts. It's still specialist assessment in a community setting. So it's delivering that specialist input in just a different setting. So it's not that you're getting you're getting a leaner version or something else. You're not getting the same service. It is that the same people who would diagnose you in the hospital diagnosing you in a community setting, or GPs with specialist interests in heart failure.
This is like Elon Musk's rocket versus warp factor 9, Scotty.
I mean, it sort of goes back to, I was about to ask you, Nick, as a patient who's been diagnosed with heart failure, in the past, the core philosophy, because this developed out of a heart failure patient charity, Pumping Marvellous, isn't it? With clinicians like us contributing to the concept. The whole problem of the delay in diagnosis, it's not just that there are these people waiting for treatment. There are people who come to harm due to that, isn't it? They get diagnosed in an emergency setting, they get hospitalized, and indeed some of them unfortunately die while they're waiting for the diagnosis. So that if you keep that as the core reason as to why we have developed the need to shake things up, the need to revolutionize the system, the tried and tested is not working. It's like passing sideways and passing the ball back constantly. It's just not working. People might think that it's the safe approach. It's not the safe approach. There are patients coming to harm due to the delays in diagnosis. The system is suffering the consequence of that as well, because you're diagnosing people late, they're far more unwell, the treatments are being delivered late. So if you keep that as the patient-delivered core philosophy, can you give us some insights as to what the patient barriers, from a patient charity perspective, what are the voices that you've heard from everyone from Pumping Marvellous?
I every time we let people into our community, there is a cohort of those people who want to tell their story. And 90% of that blurb which they give us, a super insightful blurb, because it drives us to focus on the things that matter for people. 90% of that blurb is how my diagnosis happened. It's not about anything else really. It's all about the journey that they had from their symptoms, their debilitating symptoms, and however that manifested itself to actually realizing that having a diagnosis of heart failure was an end to a lot of those mental health challenges and depression. Why is this happening? So diagnosis is, although people who, if you ask them 24 months after a diagnosis, it may be very blasé. When it actually happens, it's very, very important. And it's not just necessarily the diagnosis, it's also why heart failure. And a lot of people learn of the why, and that's very important to them as well, because they need to understand why they've got heart failure. Sorry, Fozzie.
No, I was just going to pick up on that. It's like we keep asking, we keep saying that we want to be a patient-centric healthcare system, but when the patients, the people, the charities tell us what people want, and how a diagnosis of heart failure shaped the landscape, there's almost like you always remember the time you're diagnosed with heart failure. We're still not listening because we're getting the same stories repeated.
But mine was like a condensed. You could probably find it on Google, to be honest with you. But it was a condensed version of maybe a 12 months long. And women, the anxiety aspect. I mean, there was a guy in one of our Beat Street clinics that was exhibiting classic heart failure symptoms and got diagnosed, and wasn't diagnosed, but was given sertraline for, and it didn't make any difference. So it's a faceted, multi-dimensional issue that has a huge impact on people's quality of life. And what does quality of life mean? Well, quality of life is very individualized, but there's certainly the mental health, the ability to push on through some of the symptoms that are very debilitating, certainly breathlessness, which obviously leads to exhaustion. And then you start to wonder why you've got fluid building up in your ankles, your legs, your tummy. I was considering cutting my rings off because it was becoming, my sausage fingers were becoming so big. But my diagnosis it took about 6 weeks. But looking back, it was obvious.
And it was made in a hospital setting as an emergency, isn't it? You were hospitalized.
Yeah, my wife basically drove me through the snow, threw me into a wheelchair, pushed me in. And it took a week for the hospital because they were thinking it was an infection because of my kidney and liver function. And they didn't look at the heart. It was only when somebody actually put the stethoscope on my heart when I was in a ward for diabetics, because the guy next to me had his toe amputated. Did they actually think there was anything wrong with the heart? And it was actually the AF that, and yeah.
And sort of that powerful story, unfortunately, it happens far too often, isn't it? As clinicians, we see this. So 70 to 80% of people, unfortunately, get diagnosed during an emergency hospitalization when they're very, very unwell. And that's why this beat to treat, we think, probably is a solution to that in terms of a paradigm shift as to how the diagnosis can be made earlier. And like Fozia, you mentioned, it's not cutting any corners. In fact, it involves a lot of the sort of the technology, the point of care testing, the state of care, AI, using AI to interpret echocardiograms along with the specialist assessment. So it's actually improving some of these diagnostic assessments to be delivered in the community, but in a one-stop setting where within 5-10 minutes, you can have the results available. So prognostic therapies and life-saving therapies
so
can be started.
Just for people sort of listening to this, I mean, what was it designed to fix? What was Beat to Treat? Because Beat to Treat came from the Everton in the community project that probably nobody outside has heard of, outside the heart failure world has heard of, but it was a very important program of works. Just talk us through it, Rajiv.
So it was addressing both these problems. So it was a breathlessness diagnosis and management hub. So breathlessness can be caused by a variety of conditions, but the predominant two causes are heart failure and lung conditions like chronic obstructive pulmonary disease. And frequently you get people attending two different specialist clinics, going from one to the other, left without an answer. So you wanted to bring those two together, get a diagnosis. Is this one condition or the other or both or neither? So it sort of tried to address that by bringing together point of care testing, an AI assisted echocardiogram in a one-stop setting after a point of care NT-proBNP, but also AI aided spirometry. So the person who attends with breathlessness, they leave with answers, but they also leave with any potential treatments. So that's where the idea stemmed from. But we wanted to hone in, because heart failure is a condition which we can sort of uniquely address at a system-wide scale. Like I said, hospitalizations is one issue, but there are these life-saving treatments which can be delivered to these patients when the diagnosis can be made. So if we can bring together and reduce the waits from 6 months in some parts of the country to within 60 minutes, where we can make a diagnosis and start these treatments. So that's where the concept came from in terms of Everton. And we ran this pilot quite successfully, and we've been fortunate to get funding from the British Heart Foundation to expand on that beyond that as well.
I mean, that's really, really important, because that's system validation that there's something there that we need to look at further. But what makes this, Claire, I mean, what makes this approach different from traditional pathways?
Yeah, I mean, I think as a GP, I think the diagnosis challenge is really difficult. And, just listening to your story, Nick, I interviewed patients as part of my PhD and asked them to describe their diagnostic journey. They'd been diagnosed within the last 12 months, and nobody had that straightforward algorithm-driven diagnosis. Everybody had a story to tell, and people were really unwell by the time they got their diagnosis, often by emergency hospital admission. We wrote it up and called it From Breathless to Failure, describing these stories, which was published. And then we also published another paper looking at families and carer involvement, because actually it was often the family member that was really key to that recognition of symptoms. You say your wife drove you through the snow to the hospital. That it's a community and a family approach, and we need everybody to be aware of these symptoms, breathless, exhausted, ankle swelling, to know what to do next. And time for a blood test, ideally in primary care, so we can diagnose early. But what we need in primary care is then these pathways that we can get people into quickly. So I think as a GP, when I see people who are breathless, it can be complex. Often breathlessness isn't due to heart failure. It can be due to lots of other conditions, chest infection, anemia, COPD, anxiety. But we need to think about heart failure, particularly if patients are coming in despite being treated for those other conditions, or if they're at high risk, for example, having diabetes or hypertension. But if I can access a pathway where I can get answers quickly, then that's fantastic, because what we often find at the moment is a patient will come in and they'll either be too unwell and need to go straight to hospital anyway for intravenous therapy, or I might wait months to get the heart scan, the echocardiography. And in the meantime, as a GP, I'm sort of juggling their water tablets, their diuretics, but they're not getting the benefit of those prognostically beneficial treatments that we know, which we can only really initiate once we've got that diagnosis confirmed and we know the type of heart failure. So I think what Beat to Treat does is really brings the whole diagnostic and treatment pathway out to us in the community, so that we have somewhere to send these people. We know they'll be seen quickly. They'll get the tests they need. We need to have done the other tests, like checking that they're not anemic and, maybe a chest x-ray, make sure there's no lung cancer there. But then you guys can see them, do an NT-Pro, do an AI echo, do a full stack echo, and start them on treatment, and then they can come back to me and we can work together to optimize that treatment. But it's a really exciting pathway to try and tackle. I did my PhD, 10 years ago, and the stories are still the same that you're getting from your patient members, that the diagnostic journey is just so torturous and so distressing for everybody involved that we need to do something radical to change it.
So I think that's...
Oh, yeah.
I was just about to say, it's an important point you mentioned. So not leaving just the GP or the primary care team to deal with what can be a complex problem, an unwell patient. So the good part of Beat to Treat is, so each of these Beat to Treat hubs, as it were, the clinical responsibility, the leadership rests with a consultant cardiologist, a heart failure team. There's a heart failure specialist nurse. You have a practice nurse. You have a GP. So it's a team-based approach, and that sort of makes it better for the patient. There's a holistic assessment, and there's a broad, there's a breadth of investigations, like you mentioned as well.
Can I piggyback on the end of that. And I think if we think about heart failure and compare it to other conditions, if you have someone with suspected cancer, within 2 weeks they're moved through the system for specialist assessment. And we all know that heart failure left untreated for 6 months, perhaps, or longer. We know that heart failure's got a worse prognosis if left untreated than many of the commonest cancers. Only lung cancer's got a worse 5-year prognosis than heart failure. So we can't afford to delay diagnosis and delay treatment for these people. And what I really like, Rajiv, is what you've not mentioned is that you started this work on evidence in the community for the heart failure work some years ago. So things don't happen in medicine. Things don't happen overnight. We look for the evidence. The evidence is generated, and only then do we implement it as practice. So don't rush. Nothing's been rushed here. It's taken its time.
But what part of the patient's journey? Oh, I don't like journey. Benefits from Beat to Treat, from the A to Z of that. What part of that benefits from Beat to Treat?
I think, again, I speak, we should probably ask you in terms of a patient perspective. I think to an extent it's about far too often fighting the system to get the answers they want, isn't it? We alluded to the MOT example. If you have a problem, you want it fixed, isn't it? If it's a part, it's probably simplifying things too much, the heart or the body to a car. But you want an answer and you get a solution pretty much straight away. However, when it's breathlessness or when it's suspected heart failure, why do people have to wait so long? It's far more serious, So it's about going to the root question there, that you want a quick solution, you want an answer to a question. So I think from a patient perspective, what Beat to Treat addresses is exactly that. You're getting a diagnosis, you're getting it then and there, and if you require treatment, you get treatment started then and there.
This is what you've got, and this is what we're going to do about it. Yeah, in simple lay terms. So, Claire, how can primary care act in confidence with regards to Beat to Treat or any super hypercharged process that does the same as we do in normal practice but just glues it together differently? How does primary care gain confidence in that?
Yeah, primary care is the gateway to most things in the NHS. So around 90% of NHS contacts happen within primary care, more than 1 million consultations each day with primary care teams. So I think we are the place where we need to be recognising these symptoms, and we need to be doing the beat bit if we're ever going to get to the treat bit, which is the life-saving therapies bit. So I certainly document now beat positive symptoms or no beat symptoms. I think just by using the beat messaging, we can raise awareness amongst GPs and primary care teams, nurses, pharmacists, everybody who is seeing this large proportion of the population, so that everybody's aware if somebody comes in breathless, exhausted, ankle swelling, we just need to do a simple blood test, T for test. And then that's the gateway to something like Beat to Treat. So just to explain for listeners, these are sort of community-based hubs where if patients do have symptoms suggestive of heart failure, I could send them to the Beat to Treat. And then you would reassess the symptoms, do a point of care NT-proBNP blood test. If it's above the NICE recommended threshold, which is 400, you would do an AI echo, but they'd also get a full echo as well to check. But you would be able to initiate therapies based on the type of heart failure. So heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, all at that single appointment. And then you can write back to me and say, this is what we've done, this is what we've found, this is our follow-up. And for me as a GP, seeing that patient who is often really quite symptomatic in my clinic, having that sort of service is great for me, because action happens straight away. As you say, we need to act quickly to prevent these awful outcomes. And for the patient, I can say, there's this service, it's brilliant, we can get you seen straight away. And patients, Nick's had some fantastic feedback from the pilot sites. Patients really like the service that the Beat to Treat pathway offers, and they're willing to go, and they
the feedback
found it
was very much
positive
about
thing.
easy car parking. There's a coffee or a tea on arrival, and it took 60 minutes.
Yeah, brilliant.
And very simple, uncomplicated asks, really. And Kilmarnock, we achieved something that was a bit of a light bulb moment yesterday that I heard. I haven't told you, Rajiv, about it, but I think it's a really good thing to bring up, which is, so that's based on an acute integrated approach into the Killie community, which is Kilmarnock Football Club's charity. And it's got this nice building, and we've got a Beat to Treat clinic in there. And GPs have we've asked GPs in the Kilmarnock area and the Ayrshire and Arran Scottish Health Board in the area to refer into the Beat to Treat clinic. And the usual pathway is the GP refers into cardiology, into Crosshouse Hospital. But we've asked them to put Beat to Treat, and they are now getting referrals from GPs referring their patients in not only to cardiology, but to the Beat to Treat clinic. So we're starting to shift just by simple acronyms, really. I don't know what TREAT stands for, but we know what it means. And the feedback from patients is phenomenal, and that drives the emotion, drives the why we should do it. We have to collect the data because that's what the system demands, and we should collect the data, and it should be rigorously analysed to make sure that that data is tells us something. And I suppose the three questions that where do we wait, and when we shouldn't wait, and where do we move fast and when we could move faster, and where does speed make the biggest difference? And speed isn't I feel sometimes we use the word speed and it's frightening to people in the NHS, that everything has to be in a measured approach. But speed, by just gluing things differently together that we do anyway, and it becomes a one-stop shop. I mean, I've talked about Beat to Treat being an Amazon box that you can buy on, all right, you can't buy on Amazon, but it's the concept of having a box that basically gets delivered to the GP surgery or the hub, the new hub, and it has everything in it. And it's all, a lot of the training is done online and through Teams calls, and it's very hands-off, and it's literally a 24-hour solution. Yep. I mean, we're not there yet, but that's what I'm thinking. And, I just think that if we don't adopt it, we're missing a trick. Because I say to people that forget the medications, sorry everybody, medications and the devices, but if we can get the speed to diagnosis and get people on guideline directed medical therapies, which we know what they are. We're not saying put them all on all of them, just the ones that will reduce the risk of hospitalisation, improve people's quality of life. That is the biggest paradigm shift we can do in the 2020s in heart failure. So if we could shorten one step in the heart failure journey, which would it be? And, I think that's a good ending question to the people listening. And I appreciate everything that we've done on this podcast, because I think this is a point in time where, we need to win it.